Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Hello, welcome to today's presentation, Advances in Joint Replacement Surgery, presented by Dr. Bryant Bonner, Orthopaedic Surgeon with Washington Hospital's Institute for Joint Restoration and Research. And now, please welcome Dr. Bonner.
All right. Good evening and welcome. My name is Bryant Bonner, and I'm an orthopedic hip and knee specialist here with SAW Orthopaedic Associates at Washington Hospital. Tonight we're going to talk about some of the advances in joint replacement surgery, but there's a lot to highlight in the many years since joint replacement has come onto the scene. And so you can imagine this is just a very zoomed out 30,000 foot view of some of the innovations and advances that have gotten us to where we are today. And near the end we're going to highlight one of the cool new technological advances that we have gotten here at Washington Hospital. So without further ado, let's get started. I don't have any conflicts of interest or any disclosures to announce. And just a little bit about myself. I was born and raised not too far away from here in Sacramento, California. Go Kings. I left for about 4 years thinking I was going to come back right after college, but I did most of my training back east in Boston at Harvard for college, medical school, and also my orthopedic surgery residency, where I was selected as chief resident. I then completed a 1-year fellowship in hip and knee replacement in Salt Lake City and was fortunate enough to join SAW Orthopaedic Associates here in September of 2021. And so before we get into joint replacement surgery itself, we're just going to start at the beginning and discuss the whole reason we do for surgery in the first place, arthritis. So what exactly is arthritis? As cartilage deteriorates, the underlying bone becomes exposed, leading to inflammation and ultimately pain and stiffness. And this is typically caused by age and wear and tear, but other things such as trauma or inflammatory conditions such as rheumatoid arthritis, psoriatic arthritis, or any sort of other inflammatory condition can also lead to cartilage damage. And so the causes of arthritis are many. As mentioned, age is probably the most common, just wear and tear of the joints with activity and age. Sex also seems to play a role in that arthritis tends to affect women at a higher rate than men. Genetics, so you can blame your parents. So if your parents or other family members have arthritis, then there's a chance that you will also develop it as well. And then excess weight. Any excess weight that we're carrying is an increased factor across your joints, and so that can cause increased stress and inflammation and cartilage breakdown. The symptoms of which we've already sort of highlighted, including pain, stiffness, swelling, warmth, and if it goes on long enough, can also lead to deformities as well. Arthritis is largely a clinical diagnosis and can be diagnosed with confidence with physical exam, patient history, as well as simple imaging such as x-rays. We can also use other tools such as arthrocentesis, which is basically taking some fluid off of the joint and sending it for analysis, or arthroscopy, which is we make these small incisions on the front of the knee, and we're taking a look inside the knee with a camera. But those diagnostic tools are mainly a byproduct. More often than not, we can simply do. Treatment goals of arthritis are primarily to minimize pain as well as the functional loss that is associated with it. So we usually try to start with conservative treatment in the beginning, which include medications such as Tylenol and anti-inflammatories. We can also try injections such as cortisone or hyaluronic acid, which is also known as that joint lubricant. And then, as mentioned, weight loss is important as well. So every 10 pounds that we lose is 50 pounds less that your hip and knee joints see as well. Exercise is important as well. We try to maintain and increase that range of motion, trying to keep you as active for as long as possible on your own, as well as guided physical therapy programs can also assist with this. Alternative therapies such as acupuncture and supplements also seem to play a role and can help as well. But ultimately, as we discussed, the treatment is primarily symptomatic with conservative management. Once this has been exhausted, then we start turning our attention to the surgical options. And the three primary surgical options include arthroscopy or a scope, and as mentioned, it's surgery where we make small incisions on the front of the knee and take a peek inside with a camera. The downside of doing this in a patient who already has joint space narrowing or signs of arthritis is that with the cleanup of that joint, cleaning up the torn meniscus, frayed cartilage, and the like, our hope is always that we make you better. But there's the risk that we make you worse by decreasing that space, that already limited space in that joint. And then you can also just make no difference at all. The other surgical option includes a partial joint replacement. So this is when we just replace part of the joint. And in the right candidate, this can be an excellent procedure and provide a lot of relief and quick recovery. But if you have arthritis affecting other parts of the joint that aren't replaced, then this won't work as well. And so if you have arthritis in more than one area of the knee, then a total knee or total hip might be a better choice for you surgically. And so total joint replacement has one of the best track records for clinical improvement and outcome, and is one of the most cost-effective procedures that we have available to us. And so let's talk a little bit about the history of it, starting with the hip. So while arthritis has been present for a long, long time, what really pushed innovation in the joint replacement world was actually tuberculosis and infection. So at the beginning of the 18th century, the initial treatment for this was simply what we call excision arthroplasty. Basically, we remove the affected part, which typically was part of the ball and socket joint. We just remove it, and your issue is solved. While the pain might be improved, it was lacking in its function. This was followed by what we call interposition arthroplasty in around 1840, and that's basically where we tried to put different buffers or lubricants between the joint surfaces. So between the two joint surfaces, we try to put different things in between. So at first this started with wood blocks and then evolved to fat and tendons, and it worked so-so. In the early 1890s is when we start to see sort of turning that corner, where we first got this ball and socket joint that was initially made with ivory, and this isn't quite the initial one that they used at the time, but it was they sort of replacing that ball and socket and fixing it with screws at the time. And then in the 1900s, they then tried to put a brand new cap on the ball, and they tried molding a number of different materials, including glass, gold foil, etc., to again act as a buffer between those two surfaces and alleviate pain. But we really turned the corner in around the 1960s. Pictured here is John Charnley, who developed our modern hip replacement system, and which most of our designs are based on today. And so the hallmark of this is this low friction joint, so basically trying to simulate those smooth gliding surfaces of cartilage on cartilage. And here you can see I'm holding one with a metal ball and plastic, which have since evolved into metal as well as ceramic. And then in the 1970s, as they saw they initially put these implants in with cement, there was a question of whether some of that cement was breaking off and causing inflammation. That led to the development of the cementless implants that are in widespread use today. And one of the big things that has really been important in both hip and knee replacements is the advancement in our plastics, or the joint surfaces, to help cut down on the friction, the friction between the two pieces. And so initially when they started using a different liner to replace the cartilage, they tried using Teflon. So if anybody has used a non-stick pan, you can imagine that when you scrape it, once that non-stick is gone, it doesn't really, once that Teflon is removed, it's no longer non-stick. And then you also have that Teflon particle floating around the joint, which can be aggravating and could lead to more inflammation and joint problems as well. So that evolved with a number of different trials to figure out this polyethylene, which is a type of plastic, and it's actually used in a number of different consumer products such as Coke bottles, cutting boards, and is what our workhorse is today. And so it is great because it has low friction with both metal and ceramic parts. But the issue that we ran into is that over time, this plastic can fatigue, wear, or crack, leading to inflammation, and then ultimately some problems with the implants themselves. So we've worked on a number of different ways to try to improve this, and the latest development was in the late 90s, early 2000s, in which they figured out a way to link the different chains of the plastic polymers together, to cross-link it. They also found a way to eliminate the role of oxygen that plays in the sterilization and manufacturing of this plastic, which cuts down the wear as well. Those two things combined have really helped us turn the corner in increasing the wear and longevity of these implants. And in addition to the implants themselves, there's also been innovation in the surgical approaches that we use to help us get to the hip joint and put in the parts. And so the ideal approach for a total hip replacement would be kind to soft tissues, have the lowest complication rates, and be easily reproducible. And as you can see, there's been a number of different approaches here on the slide, and this is just some of all of them. But as of yet, no definitive answer has been quite found. But I'm going to highlight two of the most common or popular ones these days. And we're going to start with the posterior approach, which is the most common approach. It's our workhorse, really. It's nice and extensile. It gives us great exposure for complex cases, straightforward cases, fractures, etc. It is a very useful approach to know, and one of our most common ones. The benefits are that it's extensile, there's great exposure. There is some studies suggest an increased risk of dislocation, and then we have to take down some muscles, which we do reattach, but we have to take them down to expose this hip joint. The other approach that has gained in popularization recently is the direct anterior approach, and I think while this is labeled as a new approach, it is anything but. It actually came into existence in 1917 when it was created by Smith Peterson, and it's nice in that it's the one true plane that splits muscles and goes between two nerve planes as well. The benefits are that there is a lower risk of dislocation, so there are fewer precautions, and in the early part of recovery, it seems to be improved. The downsides are that it may require a special table or equipment, and that there is a learning curve for sure with this approach, but as this has gained in popularity over the past couple of years, it has increased in frequency and used in a variety of different residency programs, including my own, as well as fellowship as well. And so quickly, here is a video on the approach here. So as you can see, we're on the right side of the hip. We make our skin incision and come down. And here are two muscles, the abductor and the flexor, which we split and go in between, so we do not cut them. And then we're down to the hip joint. And so we manipulate the leg, which isn't quite shown here, to get our parts in, but that is our interval right down there. And so it's actually a pretty nice approach. And it's one that I use for most of my hip replacements, as well as Dr. Saw. And the question is, why would we consider anterior hip replacement? And I think here are some of the benefits, which include the ability to use X-ray during the procedure, which help to confirm our component position and help us dial in that leg length discrepancy as close as we can. Studies seem to suggest in the early part of recovery, pain is less, as well as the use of narcotic medication. There appears to be some less muscle damage as well. Length of stay is reduced with a direct anterior approach, so patients tend to go home earlier or go directly home. Patients seem to come off of their walker or cane at an earlier time point and seem to increase their activities as well. And then there's also, as I mentioned, a decreased risk of dislocation, so there are fewer precautions. I'm sure some of you have had a hip or know people who have had a hip replacement in the past from the posterior approach where you can't lean forward more than 90 degrees, you can't cross your legs for around 6 weeks until you scar in. The good news is that regardless if you have a posterior or anterior hip approach, that both of these do equally well long term. So there's great implant survivorship, great outcomes, and they all seem to even out after around 6 to 8 weeks. But it's that recovery in the early part of the curve that really is why I use this approach for most of my hips. As we turn our attention to the knee replacement, the knee replacements also came out of the 1800s, and as you can see here in the top right, this was that model or a schematic of the first total knee that was implanted. It was a hinge joint, again made of ivory, which was, I guess, very widely available at the time, but complicated by infection. It was very stiff, and so it kind of fell out of favor. In the 1950s, they developed another hinge joint similar to this, a little bit different, but the material they made it out was one that we now use today in a lot of our knees called cobalt chrome, and so that's that metal that you can see on this implant today. And in the 1960s, just a few years later, they developed an unhinged knee, which just replaced the two sides of the knees, as you can see in this image in the bottom right. And then in the 1970s, here is the development of our modern metal on plastic total knee replacement. And so as we continue to improve, not only our implant design and makeup, I think one of the more exciting developments in the past, 10 years or so has been in the field of robotic assisted surgery, and that is something that has just arrived here at Washington Hospital. And so I'm sure a lot of you have seen a number of different news stories or media about robotic surgery, and here are a couple of different headlines here specifically about hip and knee replacements and the use of robotics. Robotics are also used in a number of different surgical fields and seem to be growing in popularity and advancement. But ultimately, the question is, are robotic surgeries really better? But again, we have to step back and figure out what exactly is a robot. And so robot is actually derived from this Polish word, robota, meaning forced labor. And it is this reprogrammable, multifunctional manipulator that can move a variety of different materials, parts, tools through a number of different motions to perform a variety of different tasks. And as much as I wish our robot looked like this, our current robot does not look as cute as Wally here. So the robotics began being used in surgery in the mid-1980s. In the top right, you can see Dr. Kuo. He used the Puma robotic system to perform the first neurosurgical biopsies using robotic assistance. Not pictured on this timeline here is in 1991. Urology also adopted some robotic technology, using one to help with a resection of prostate. And then for our purposes, in 1992 was the first use of a robot in orthopedic surgery, specifically by a company that was founded here in Fremont. And so you can see that robot here. And there are a number of different types of robots. So we're going to start with three broad categories, the first of which is passive. And so these are computer-assisted or computer navigation surgery systems that help to monitor the progress and provide surgeons with data during your procedures. So you can see here there is a camera here that then registers these navigation marker balls here that can tell you where your cutting block is, or where you made your cut, or how your joint surface is angled as well. But it's mainly just to track, how the progress of the surgery. Next is what we call semi-active robotic systems, and this is probably the most popular type of robotic category at the moment. And so these systems limit the range of movement of surgical instruments that are controlled by a robotic arm through a plan that's developed by the surgeon and the computer to help navigate the cuts and the surgery as a whole. It also provides a tactile feedback to the surgeon throughout. So the surgeon can move the instruments freely within these pre-programmed barrier or virtual boundaries that you develop with a plan during the time of surgery. And so all these actions are performed according to the preoperative and intraoperative plan, and the final manipulation and actions still depend on the surgeon. And then lastly, you have your active or autonomous robot, and so these complete tasks completely independent of the surgeon. You do develop your plan and you put in your plan, but once you have identified the patient's anatomy and put in your plan, as the surgeon, you take a step back and the robot will make the cuts for you. In addition to these three broad categories, each one of them can either rely on an image beforehand, preoperatively, or one without. And so All of our robotic systems in orthopedics currently require a pre-approved plan, and I think this presence of a plan to execute is one aspect of robotic surgery in orthopedics that differentiates it from other surgical specialties that use robots. And so the patient's anatomy at the time of surgery has to be mapped with various points during the registration process, so that the robot knows where the tools are at in space in relation to the patient anatomy. And so in image-based systems, this registration is directly tied to the preoperative imaging. Currently that is CT, which you can see here on the screen, or an MRI. And then these 3D images are used with the software before the surgery to help identify bone resection depth, target postoperative alignment, optimal component size, leg length, offset, etc., and during the time of surgery. And then imageless systems also rely on the registration of patient anatomy, but after the surgical exposure in the operating room. And this helps us create a virtual model and ultimately a surgical plan that is then executed during the procedure. And I think some of our systems tend to be moving towards this imageless platform, as insurance companies may give some pushback on now getting that preoperative CT or MRI imaging. And so there's been a flurry of research on robotics in both hip and knee replacements, but right now the biggest area of use currently is in total knees. But at the end of the day, what do these research studies show? And I think the two main advantages of robotic surgery include increased accuracy as well as the precision of the component placement of both partial knees, and total hips. And at the end of the day, this improved alignment, in theory, should help increase the survival of the implants that we put in, as well as increase patient outcomes and patient satisfaction, and ultimately decrease the rate of us needing to go back in and do a repeat or revision surgery as a result. But that's not to say that robotics doesn't have its own limitations. There's certainly a learning curve, so it takes some cases under your belt to get more facile with the instruments, and so at the beginning you can have increased surgical time, which also can lead to some increased financial costs. These robots will make very, very precise cuts within about a 0.5 millimeter, but it is still important as you, as the surgeon, provide the adequate exposure. And you have to, as a surgeon, really need to put in good data to generate a good plan for the robot to execute. And at the end of the day, I think we just need more long-term research studies to really further evaluate, how much better these robotic systems are. The good news is that regardless of whether you have a robot or just your surgeon as usual put in the implant, that the long-term functional outcomes that we have up to now seem to suggest that they both do equally well. And so, but the prospective advantages of having increased precision and better implant placement are the reason that I tend to use the robot for most of my total knees these days. And as we start to look to the future, I think robotics are here to stay. Given the universal history of robotics in a number of different fields that have shown to improve performance, from manufacturing to aviation to financial services, I think robots will be here for a while and will only continue to become more visible. And so as a result, I think we're going to work on helping to streamline the planning, the setup, and the overall workflow during robotic-assisted surgery. And then we're also going to, I think artificial intelligence is also going to be important, or something that is going to be more relevant in the future in helping us to preoperatively plan as well as interoperatively adjust if the cuts aren't quite right, or if there's unanticipated ligament damage, and sort of adjust on the fly to suggest different techniques to get us to where we want to be. And then augmented reality is now being used in some total hip and total knee surgeries as well, and something that I think we're going to have to wait and see how that plays out as well, but with that is becoming more and more popular every day as well. All right, and thank you. If you have any questions.
Yes, thank you, Dr. Bonner. We do have a few questions here. The first question is, what is the average age of a joint replacement patient?
All right, that's a great question. So the average age of joint replacement actually is continuing to fall. I think the average age of a total hip is around 63 now, but that's down from 65. And total knees are now down to, I think, 66 from 68. And I think as our patients are now striving to remain active longer and are more active, and our implants continue to improve, we anticipate this age to only continue to drop younger and younger.
Thank you. The next question is, how long does a joint replacement last?
I think typically we used to say around 15 to 20 years for a joint replacement, although I think, with our improvement in our implant materials and surgical techniques, our hope is that this is going to last even longer and hopefully your lifetime. I think one of our biggest turning points was in the evolution of that plastic between the metal surfaces. That was one of our weakest points, and so now that seems even more durable and likely to give you even more life out of that implant, that should improve. And then the robot, adding some increased precision of those implant placements, may also offer better kinematics and alignment for that implant to also wear less or at a lower rate, and so that these will last longer.
Thank you. The next question, you mentioned several robotic techniques. Are they all used at Washington Hospital?
Right now, the current robot that we have here at Washington Hospital is this semi-active type of robot, which does not require any sort of preoperative imaging. So just as a reminder, these semi-active systems help to limit the movement of surgical instruments in these virtual boundaries that we set. And so we put in this preoperative plan and define these boundaries at the time of surgery, and can adjust based on this screen here to get the appropriate balance, alignment, and positioning.
Okay, that brings us to our next robotic question. Who is a candidate for robotic joint replacement surgery?
That's a good question. So the good news is if you are a candidate for a joint replacement, then you are a candidate for a robotic joint replacement as well. As mentioned, right now robotics primarily are used in total knees, but I think as long as you are a good candidate for a total joint replacement, you are a good candidate for a robotic joint replacement.
Great. Let's see. Now, last question here. How long is the hospital stay with a joint replacement?
Yeah. So typically our hospital stays are around 24 hours or less. So many patients actually go home the same day of surgery, while the others tend to go home just the next day after surgery. And most of them go home.
Good. Okay, that is our last question. And we'd like to thank you, Dr. Bonner, for this insightful presentation. This concludes our program, and we'd like to thank our viewers for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.